Yeah. So now moving on to the next patient. So we had a 54-year-old male who had an alleged history of RTA, and he had skid and fell from his bike. So he was taken to an outside hospital. He had a plain CT of the chest and abdomen. The reason we are highlighting this is, remember in trauma, so when you do a CT of the torso, the chest and abdomen, you have to always ask for a contrast CT. So you can't figure out where, if the patient is bleeding or where he is bleeding if you do a plain CT. So it's a bad idea to do plain CTs. So chest and abdomen CTs in trauma should ideally be contrast enhanced CTs. Yeah, so anyway, so this guy had plain CTs outside and it was normal. And he complained of pain in the abdomen and in this knee. So what do you see? So you can see that he's got a proximal tibial shaft fracture. He's got a comminuted fracture of the tibial shaft. Tibial condyles and the tibial plateau. So I can't see any fractures in his pelvis. So this guy was given, he only came in on room air, so we gave him lots of oxygen. I keep reiterating, high flow oxygen is the way to go in all shocks. So the guy had a respiratory rate of 25. He had cold peripheries, feeble pulses with really low blood pressure, 60/40. Yeah. The GCS was 15. Despite that, he seems to be perfusing his brain for the moment. And he had multiple abrasions in his shoulder, knee, which was grossly swollen, as we had seen the X-ray, and it was deformed. The EFAST showed free fluid in the abdomen. So where do you look for blood in trauma? So chest, abdomen, pelvis, long bones, and the floor. So we do know that he had a long bone fracture, but that would only account for 1,000 mils max. So this guy is in refractory shock. He's a non-responder. He's having fluids, despite which his BP is 60/40. So he has to, non-responders often have a blood loss of 2 liters plus, 40% plus. Yeah, 40% of the circulating volume or more is lost. So when we put the probe in the belly, so we could see that he had free fluid in the abdomen. Yeah, so he had only 500 mils of fluid. In case you are wondering why, so remember, any blood loss should be treated or sorted out only with blood and blood products. So you do not give fluids. Fluids are harmful, detrimental. So, but for a time buying measure, till we get if you don't get one egg, so for them to give you a type specific blood, it might take up to half an hour. For that reason, so this guy was given 500 mils as a stopgap. He had an art line which showed a 80/50 opening blood pressure. He was transfused. Principles about transfusion. So after the first 2 packed cells, you need to give FFPs if you're giving further. So this guy had packed cells, FFPs, and we also gave him some platelets. He had a central line placed and he had blood pressure improved to 110/760. If you notice carefully, we never at any point thought of giving him Norid. Vasopressors aren't to be given in somebody with hemorrhagic shock. So you need to stop the tap. You need to replace blood and blood products. That's how you treat hemorrhagic shock. Yeah. So this guy should have had a bound pelvis. So which we did. We did have a pelvic X-ray, but we would have bound his pelvis. Yeah. So we also went ahead and did a pan CT to find out where he was. His plain CT outside was normal. Remember that. Yeah. So he had a contrast CT. 30 minutes from his arrival time, this guy had a PA arrest. So luckily we got ROSC. So we kept giving him PRBC, and subsequently, as we couldn't convince the surgeon to take him to theater. Ideally, he should have gone straight to theater. So we did a CT. So you can see that you can see that there is a collection right around the right kidney. And you can see that there is a, liver lac as well. So he had all these injuries. He had extensive intraperitoneal blood, but all those were contained. We were wondering, why is he arresting? So then we could see that he had a hepatic artery bleed. So the blush that you see here, yeah, is because there is an arterial bleed. So that would explain why this guy stabilized first and then subsequently went sick and arrested again. So this guy had to be referred to the interventional radiologist. So in a way, the surgeon's stand was vindicated. I did tell you that I want a CT, was what he said. And to his credit, this guy was treated with interventional intervention. The radiologist coiled the hepatic artery, and that way he was saved. So should we give more fluids? No, I already told you fluids are detrimental. Specifically, saline is harmful. So if you have to give fluids, just do it till you get that first pack of blood rushing. Yeah. Should we initiate NORAD? Never. Or you shouldn't think of it. You need to think of more blood and blood and more blood. So NORAD is very widely done in hemorrhagic shock, but not ideal. Wrong practice. Should we start injection adrenaline post-cardiac arrest? Maybe not. You need to keep giving him blood products again. So what should be our resuscitation endpoint? I'm sure you all know the answer. Adequate perfusion to end organs. How do you assess that? Mentation to see if the brain is perfused, and urine output. Is he making 30 mils an hour? So those two are the best. And maybe if you want to do it with biochemistry, you need to do the lactate. Your blood gas will tell you that his lactate is under control or it's going down. Lactate clearance more than lactate measurement per se. It's a good choice.